Welcome to the LowCarbUSA podcast, where we seek to inspire you to help us build this community. I'm Doug Reynolds.
And this is Pam Devine.
Okay, so Arthur, welcome. I'm so glad to finally have you on here. I thought for this podcast that we should kind of focus on what I didn't even realize until very recently was what you kind of famous for is the Agatston score, the calcium score. I think maybe the way to go with this is explain to us why it is that you decided this even became necessary to come up with this thing. And then maybe describe a little bit about what it is and how it works.
Sure. Well, I became interested in preventive cardiology because when I was growing up, that's when the really big risk was friends' fathers dropping dead of heart attacks, and was always concerned about my dad. He became home late. And so I was interested in prevention. When I did my cardiology residency and fellowship, it didn't seem like we were doing much for patients with heart attacks, and certainly not prevention. As in the 80s, becoming an attending, I was very impressed with Dr. Castelli's talks about Framingham and how important it was to lower cholesterol on a low-fat diet. And of course, that wasn't working well. A few years later came the statins, where all of a sudden we could really knock the socks off of cholesterol for the first time. And anytime you mention diet at that point to a cardiologist who had started to use the statins, they'd say, well, the diet never works. So I was interested in prevention and diet. Now, once we had the statins, the question was who to give them to. Because if we gave them to just people with super high cholesterols, we were missing most of the population, because most people who have heart attacks don't have very high total cholesterols, don't have high LDLs. And so, we were missing too many people. The other thing is just to give everybody statins, but then you're giving statins to so many people who don't need it. And I knew about coronary calcium. The chief of cardiology at Sinai in Miami Beach, where I was working, Phil Samet, was the last cardiologist in the country. He actually did fluoroscopy on all patients looking for coronary calcium. That was mainly people with chest pain, whether to take an invasive route. But because of that, I knew the coronary calcium literature. And then when there was this new technology with CT scanning, it was the Imatron Corporation, the ultra-fast CT scanner, and that was different because it could shoot a scan in a fraction of a second. So it was like a camera with a fast shutter speed to stop a racehorse, so it doesn't look like a blur. So at that point, the traditional CT scanner took a few seconds to acquire an image, and if it was the heart, it was just a blur. So when this fast CT, they were using it for kids, because if kids move, you could still get an image, and they thought it might be good for the heart. They were just using it like a substitute for an echocardiogram for left ventricular function. And they showed it to our group, and there wasn't much of an interest. And one of their engineers, David King, who really helped pioneer all this, said, could there be other uses? That he knew that you could see calcium, including in the heart, with a much better resolution than on fluoroscopy or other ways. And then, because of my background with knowing the fluoroscopy literature, and I knew a couple important factors. That number one, this I learned from Bill Roberts, who had been chief of pathology at the NIH, later chief of cardiology at Baylor, that anybody who died with heart disease or presented with heart disease, whether it's just angina and later died or bypass surgery, they had diffuse atherosclerosis. They had some atherosclerosis in all their vessels, advanced, and plaques really in all stages. And that we knew from pathology studies that the coronary calcium reflected the total plaque burden. So I'm thinking, God, if we can quantify coronary calcium, we can quantify atherosclerotic burden, and then we'll know ahead of time who is at risk and who we should give the statins to, even if their cholesterol level was not very high. And so we, with David King and with Warren Janowitz, he was a radiologist, happened to be an engineer and an internist, understood everything. They really came up with the protocol, and we grabbed some doctors out of the hallway, threw them on the scanner, and came up with these incredible images. So at that point, we just we took a lot of people with heart disease and people without known heart disease, did their scans. We came up with a score, which Warren Janowitz and I did over lunch one day. We didn't know it would become a big deal. But there was dramatic difference in the amount of calcium in people with coronary disease in those without. It was, if you looked at total cholesterol, LDL cholesterol, and took the normal curves of population distributions, there was a large amount of overlap. In the Framingham study, at that point, the average cholesterol in the population was something like 220. Now it's a little lower, but it was not much different in their patients who had coronary disease. If you looked at the two curves, you really couldn't distinguish. The distribution of coronary calcium, you really, really could distinguish. And the ones who didn't have coronary disease, who had high calcium scores, you knew were headed for trouble. And so we did the first study, was published, I think, in 1990, maybe 1991. And so from then we had a group, we called our coronary calcium club, with people, John Rumberger from Mayo Clinic, and you know, a bunch of other people, some of whom had been doing research still in fluoroscopy. And we thought there was evidence then, when you didn't know who to treat aggressively with these new magic drugs, the statins, and diets that didn't work, that at least we should know who to give the statins to. And there were a lot of concordant studies done at Mayo, at the University of Illinois, by Bruce Brundage, and you know, others done at Long Island, St. Francis, and all showing the same things, is that coronary calcium was an incredible marker of total plaque burden and prognosis. And then later, my partner, Khurram Nasser, who's now head of prevention at Methodist Hospital in Houston, came up with the concept of the power of zero. If you don't have plaque, it doesn't matter if your cholesterol level is 300, your prognosis is excellent. If somebody's developing diabetes, insulin resistance at a later age, you do have to repeat the scan every few years instead of every 5 years with a zero score. And so it comes up in the lipid world, in the nutrition world, the low carb world. You know, do we treat this high cholesterol or not? And you know, we have the answer. You do the calcium score, and we now know from the distribution and size of the coronary calcifications, you can tell the age of the lesions. So if you see a large lesion in the LAD, a large calcified plaque, it doesn't mean that that's obstructive or more obstructive than a smaller one. It means it's been there for a long time, 10, 20 years old. And we can kind of tell. If you see lightly calcified lesions, those are relatively young. It means that there's been a degeneration or plaque rupture in recent years, then a clot, then scar, and it's just beginning to calcify. So it means more active disease. And one of the things in the early days of looking at the coronary calcium and seeing it in many people who didn't have very high cholesterols, then it came 1988, where Dr. Reven gave the Banting lecture about Syndrome X, insulin resistance pre-diabetes, and Dr. Ron Goldberg at the University of Miami taught me about that and said, look for it in my practice. And so we're seeing all these people with relatively high A1Cs and often very low cholesterols because they had very small LDLs and they had low levels of HDL and they had coronary calcium. And so we knew the low-fat diets just weren't working. And from seeing the experience of Atkins, although at that point we didn't want to give our heart patients a lot of saturated fat, which I think Atkins was right, we were wrong. But we had some other, we realized it was the quality of carbs and fats, not the total amounts that were important. Yeah. And that's what led to, I was the director of cardiac rehab at Sinai and worked with Marie Alman, our nutritionist, to develop a diet, a low-carb diet. We did a small clinical trial. We reported at a national meeting, and the local media, the ABC affiliate, asked us to put South Florida on the diet. And we did, and they won their sweeps, and it became a big deal in South Florida. People were asking us to send them copies of the diet, but everybody said you had to write a book, and that led to the original South Beach diet.
That's how it became the South Beach diet, right?
And that became the South Beach diet, and so that's how it all started.
Oh, that's really. So I'd like to go back to the statins thing. I mean, one of the things that you said was that we missed a lot of people, but that was because most people who had heart attacks had relatively low cholesterol levels, right?
Yeah. Yes.
So we're giving statins to lower cholesterol to prevent heart attacks when the people that are having the heart attacks don't have high cholesterol. I wasn't even aware of that statistic, to be honest with you, which even more just solidifies everything that we're doing, yeah. Right? So, in those days you were talking that statins was the thing. You treated it if the calcium was high. Nowadays, I'm assuming that we've moved on a little bit even from that, and that even if it's high, do we necessarily want to give statins to people? I've heard a lot of people recently talking about the fact that you look at Dave Feldman and they're talking about, and all the research that he's doing in that, and it's coming to this stage like, is cholesterol actually a marker for disease that needs to be trigger treatment of some kind? Yeah. Or is it really that there's all sorts of other things in play? And I feel like you mentioned it, that the South Beach diet is one, and obviously the keto diet and low carb, which is what we're all about. I feel like that is just so much more effective in trying to help treat and prevent this stuff than trying to give people statins that have a high cholesterol.
Well, no, I agree. And in our overall approach to people, if we find them early, and one of the things is just like there have been a lot of people walking around with coronary calcium and don't know it, preclinical disease. There are a lot of people walking around with insulin resistance. They don't yet have, they have A1Cs, in the fours. They're not considered pre-diabetic. They have sometimes pretty small bellies. One thing we do when we do the calcium scans is we look below the diaphragm, and a lot have visceral fat, the so-called tophies. They're thin on the outside, fat on the inside. If you see them in airports, you wouldn't say they were really overweight or obese, but they are insulin resistant. And with insulin resistance, there was a very good analogy I heard from Jason Fung that the insulin resistance is giving the fertile soil for a number of genetic factors, which are the seeds. So given if you're in sub-Saharan Africa or a hunter-gatherer society where there's no insulin resistance soil, they have the same seeds we do. They have the high Lp(a) and even familial hypercholesterolemia. But when there's no soil, there's almost no coronary disease. In America, it turns out, almost everybody has the soil. The majority of Americans, and the way we measure things is with our Kraft test. You have to do postprandial insulin. You can't go by A1C or fasting insulin to pick up these people. So somebody who's heading, just like we mentioned, somebody's heading for a heart attack in their 60s, they have coronary calcium in their 30s. Well, if you're heading for diabetes in your 60s or 70s, you're insulin resistant in your 20s and 30s. These studies have been done with the euglycemic clamp tests, which are expensive and cumbersome, not good for clinical use. But when you use the Kraft test, where you're doing essentially the glucose tolerance test, but doing insulin levels, you pick up these people. And so with those people, if you get them young and you reverse their insulin resistance, even with high cholesterol, not very good genes, and we're treating people like that. They don't want to take a statin, don't want to take medication. And I say fine, as long as we have one he was 35 when I first met him, already had coronary calcium, bad family history, but with aggressive low carb, and we do in our practice low carb, as well as fasting, intermittent fasting, and keto, depending on the individual patient. But he's done incredibly well, and we repeat his calcium score every few years. If it doesn't increase, we'll do no statins, we'll put him diet alone. Yeah. When somebody has advanced further, and if they do have a lot of the seeds, then what I described, to overcome the genetic component, you may need medication, including statins. And again, we see people very high cholesterol, 0 calcium scores. That's that power of 0. We don't treat them. Taking people in their 60s, 70s with cholesterols well over 300, follow them for 10, 20 years, 0 scores.
No buildup, yeah.
And there's no reason to treat them. So we take people off statins, but statins are great drugs when used selectively. And so so it depends on the individual, and it depends on the genetic component versus a lifestyle component. We'll have somebody, in their 60s. There was a fellow recently in his 70s with a belly over recent years, with a moderate calcium score, but no other genetic risk factors. And we're treating him for now aggressively without medication. Drying up that fertile soil so the genetic seeds don't grow is extremely important. And theoretically, you can do it later in life. Once somebody has a high calcium score and high risk, it's a risk-benefit ratio. And I don't want to bet their lives on not getting their LDL cholesterols, and particularly their small LDL cholesterols, down a lot.
So, and I think that's a thing that's been shown, with the keto diet and the low carb diets, and that's one of the things that does improve drastically is that ratio of small dense to large fluffy.
Yes.
I'm not thrilled with that description, but for lack of a better one.
Well, we do. It's most they're shown in many studies now that it's small LDL that predicts future heart attacks much better than large LDL. In fact, large LDL going up is mainly a marker. Now, there are, if you have familial hypercholesterolemia or a problem with PCSK9 genes, where it's a receptor problem and you can't clear LDL. In that case, large LDL can be atherogenic also. But the great majority, it's small LDL coming from insulin resistance. There are a few people, I learned this from Ron Krauss, it's actually not that few, that have congenital small or very small LDL. Mm-hmm. That's another place where you need medication.
Well, those guys are at risk, yeah. The calcium score, we're talking about people that have a fairly high score, say, and then you're saying like every few years they need to keep having the test done, and the idea is to try and make sure that there's no progression of the growth of that calcium, right? So by changing the diet and possibly even drugs if necessary, you want to halt that growth of the calcium.
Yes.
So I know we spoke about this the last time we were chatting, I think, is that it's like that becomes pretty stable. And you were saying that it's actually the newer soft plaque that is really the stuff that's at risk, where it can possibly break away and then downstream cause a blockage.
No, exactly right. So depending, like the 35-year-old I mentioned, once he's stable, we'll do fewer and fewer tests. Now, the good news is the calcium score today in most places now $100 or
really
less.
Cheap, yeah.
It's not, and the radiation with the new gating scanners is less than a millisievert. It's not an issue. Mm-hmm. It's not like a whole body scan used to be. So it's low risk to repeat the calcium score. We don't start, usually we do men over the age of 40, women postmenopausal over the age of 50. If there's a strong family history, even like the fellow we do at age 35, because his father had a heart attack at a young age. And again, it's, the risk is so small. And we also, if somebody, the other thing about lifestyle, I mentioned this fellow in his 70s that we're treating with diet alone, his calcifications were young, meaning it came with an acquired risk that he didn't have lifelong exposure. So we see somebody in their 50s, 60s, 70s who were born high Lp(a), some other genetic problems, they will have big chunks of calcium because it's been there for a long time. If they've gained weight in their 40s, 50s, 60s, like this fellow did, and we see young plaques, that means they formed relatively recently, and we can be more aggressive with diet versus going after the genetic factors. So this is, this is something we sort of see very easily. And if we're treating aggressively, successfully, the old plaques can still get older. It's areas of scar that is still getting calcified over time. The lesions are not more obstructive. They don't all of a sudden develop angina from those lesions. But as long as they're not developing new lesions, and we have people we followed 20, 30 years, they have a lot of big chunks of calcium at the beginning of their vessels, and then nothing, because we've stopped the progression
of it, yeah. And the scan itself, does it pick up the soft plaque, or does it?
No, that's another good point. With CT angiography, you can pick up soft plaque, but that's giving dye. It's more radiation.
Right. That's a much more intrusive test, right?
And if you're following a chronic, stable patient, the young plaques that just started to calcify, it takes from 6 months to 2 years, where if somebody's had a new thrombus from a rupture or a degenerated plaque, and we know from ultrasound studies, it takes from 6 months to 2 years before you'll see it on a scan. But you can still see the young plaques, so you can see if disease is active. If I have somebody again in their 30s, where there was a lot of heart disease in the family, I say on one side of the family, not on the other, we may do a CT angiogram to look specifically for soft plaque, to see whose genes they got and how aggressively to treat them early on. But the soft plaque, it's been shown, if you're evaluating somebody in the emergency room, you don't die with your first soft plaque rupture. Flow is very strong. It's not until you have a really lumpy, bumpy vessel with a lot of plaque that you're really at risk. And that we know from both pathology studies and following big cohorts with coronary calcium. Yeah. So finding one soft plaque is not, it's not a cost-effective, good thing to do.
Yeah. So talking about insulin resistance, that kind of brings up another thing. We're in talks with you. We have developed a mentoring program or a coaching program to help people adopt this lifestyle, both in nutrition, and we've added this exercise component with Dr. Ben. And you've become familiar with Dr. Ben fairly recently and been involved with even, teaching a lot of your patients about to do this. And you were just telling me before we got started how impressive some of the results were. So maybe you can tell us a little bit about that.
Yeah. I saw Dr. Ben's first YouTubes over last summer, and it's interesting because of COVID and all, I wasn't doing my usual exercise. I box, nobody's allowed to hit me with mitts against a good trainer with mitts. Still, it's a lot of exercise and play tennis singles and doubles. And over the summer, I was away a good part of the time, because of COVID. And I started doing Dr. Ben's routine when I wasn't doing my other usual exercise. And I came back to South Florida, and all of a sudden I was able to box and tennis, including singles with a pro. And I thought I was going to die. I was going to do a few rounds and finish. And from doing just really the resistance, I was playing a little doubles during this summer, but not much. My endurance was there, and I became a big believer in Dr. Ben. And then we started doing, putting our patients. One fellow, one of our best examples, is 73-year-old, big belly. Actually, the father-in-law of one of our nutritionists, who had bypass surgery, had A1Cs in the sixes. He may have even been diabetic. A couple months before I saw him, our nutritionist put him on our diet. He lost 11 pounds. His A1C was down to it was 6.1 when she started. It was down, it was 5.3 actually already when we saw him. Continued the diet. At first, he lost 10 pounds in 4 months, and he was doing aerobic exercise, walking and all. Continue on the diet. Lost 10 pounds, but we use this Fit3D. It's really an avatar where we can see what's lean body mass, percent body fat, and fat mass. And he had lost 5 pounds of fat mass, but also 5 pounds of lean body mass because he wasn't carrying around this, I call it the front pack, as opposed to carrying around a backpack. When you're carrying around more weight, more stress on your muscle and bone, and you increase your lean body mass. So too many people, when they lose some of that extra weight, carrying around, they're not carrying around that front pack, they lose lean body mass also. So over the summer, I sent him Dr. Ben's YouTubes and told him what to do. He's a very compliant fellow. He came back, was a little delayed because of COVID again, but when he came back, his weight was the same. So say, that's too bad, you plateaued, but he was feeling great. When we put him on the Fit3D, he had lost another 5 pounds of fat, and he had gained 5 pounds of lean body mass.
That's incredible.
And his A1C at 73, a guy who had been pre-diabetic or diabetic, went from 5.3 to 4.9. And we have many other examples. He was a particularly nice example. We had the control, and then the resistance training, I call it my Dr. Ben approach. And so since then, we've seen that building, it's those type 2B fast twitch fibers, I'm convinced that really makes a difference. And you sustain your aerobic capacity as well as your anaerobic capacity. And high intensity intermittent training helps. I always thought the sprinters were ripped compared to the runners because they were sitting in the gym doing weights all day, but I found out, no, it's when they hit the anaerobic threshold with exercise, they stimulate those same 2B fast twitch fibers, and that's why they're much more ripped, less percent body fat than marathoners.
Yeah, because I mean, you find even with a sprint, I think, because people have often asked Ben when we have him on, isn't there another kind of exercise or something? Because I hate going in the gym and all that kind of stuff, And he's, well, you could try and do it in not an aerobic, but in an athletic type environment like that, where you sprint 100 meters. By 60, 70 meters, you are maxed out.
Right.
And which is what you need to do that's the whole point of Dr. Ben's exercise protocol, right? It's taking those muscles to failure, real failure.
Yes.
And you can do that. You can sprint in 70 and then keep going through to the finish, maybe go a little bit further if you only hit that threshold at the finish. And you can do that, and that you need to do it once, right? Twice a week. You need to only reach that threshold once. But people aren't going to go out and do a 100-meter sprint or something and really go full tilt so that they actually, like these guys that are competing in the Olympics and stuff, when they literally hit that threshold, they hit that wall. People aren't going to go out and do that. Or on the STEM machine or something. You're just not.
And by the way, you're talking to a good example, because I've always loved to exercise. I've been athletic, and I love my tennis. I love my boxing, but I never liked doing resistance exercise.
Right.
I've done it on my own. I had trainers, and I don't like them screaming at me, one more rep.
Yeah.
But I said twice a week, 15, 20 minutes.
For
I still
15
take
minutes,
a little
exactly.
longer. I can do that, and I can. Same with my patients. And I frankly can't stand, running on a treadmill or the elliptical or all that boring stuff. So this is such a great solution, and I've still learned how to do it better and better, and get the right weights, and to failure when you're not going to injure yourself. And
actually, we had him here a few days ago, and every time we end up meeting up with him wherever, I find a way to get a workout in where he can be there, right? And
you're the workout I started watching from
on
YouTube.
Every time he comes back and we do it again, there's like stuff that he tells me that I'm doing wrong, or I could be not doing wrong, but could be doing better, in order to be even more effective at reaching those thresholds and encouraging that upward growth as he.
But when I come out to San Diego, I want a personal session as well.
Oh yeah, for sure. We'll sort that out for sure. When you're.
I've been talking with Dr. Ben and getting more more information.
We're actually going to have some equipment in the because we're kind of showcasing that mentoring program, including all the exercise. So we're going to have a couple of multi-gyms and stuff like that in there. But they also have a gym in the hotel facility. So between the two, we'll definitely get. And for
people who have plateaued with their diets and all, I think this is an alternative we never really had before.
Right. Because up until now, everything that I learned and everybody else has been learned, most people still learn about the keto diet or the low carb diet is like, it's not about the exercise. It's about the lifestyle and the diet, right? And eating right. But that was when we were talking about aerobic exercise and when we were talking about the old concept of exercise. And Dr. Ben just brings a whole new concept to the floor. And it's a perfect synergy between the lifestyle and now adding this exercise component in.
And what's so important, and one of the things we're working on is creating a training program for postgraduate cardiology fellows and others. But the reason is in prevention, there are all these different silos. And, I got into the imaging silo. I'm interested in diabetes and lipidology, genomics, nutrition, fitness, but you can't be an expert in all those. And so, and I learned so much, talking with somebody like Ron Krause, who's a true lipidologist, knows the genetic predisposition of everything, but doesn't, and uses some coronary calcium, but not that much imaging. And at the low carb meetings, you see people with questions. Well, their total cholesterol, their LDL is going up. Well, is it large, small? What's your calcium score? What are your other possible genetic predispositions?
Exactly.
And so we have to bring the different silos. And fitness was not a major silo of low carb or prevention, because the conventional reasoning was you couldn't outrun a bad diet, which I think you couldn't. But the resistance versus aerobic,
completely different.
I think is being solved. But
and I think the reason most people like you, and we were talking, Dave Feldman was talking about it as well in our last Grand Rounds discussion. Like, I hate gym. He was trying to find another exercise to do or another way, some form of exercise, because he didn't want to go in the gym. But we're so used to going in there with a trainer who makes you do 4 sets of 10. Of each exercise, and like the last 3 count, it's the last 3 reps count. And that's what Ben says. Why don't you just do the last 3 reps and be done with it, and then move on to the next one? And that way,
all the time.
Yeah, that way you don't get bored with it. You're working really hard, so you're concentrating, and you move from one to the next, and boom, it's over before you even realize it. It's over.
Yeah, it's
there's no time to get bored.
Here at work, if I travel,
Yeah.
machines,
Exactly.
you can do it, with or without.
Yeah. No.
But I never like going to the gym. I don't mind if my boxing trainer screams at me and makes fun of me, but I don't like it if it's a
Yeah. If it's
resistance trainer.
some buff guy trying to tell you to do 40 reps, Yeah. No, that's brilliant. I'm actually really looking forward to meeting you in person in August. For those who are listening, you will be coming and doing a presentation, as a talk there. Maybe just as a bit of a teaser, you can give people an idea, because you're a whole lot more than the Agatston score guy, right? Your contribution to this community is huge. So maybe just give people a quick idea about what they might be hearing from you at that talk.
Sure. I mean, one thing I am, and we have a lot of great cases. They come every day. People who come to see me tend to be people at risk with high calcium scores. So sometimes it starts with that. We start with the atherosclerotic burden. And that's the early preclinical disease. So I want to show how we start and evaluate high-risk families, high-risk patients, and starting with the plaque burden, but also some of the myths about coronary calcium. Again, that large plaques are more obstructive. No, you worry more about the smaller, less, given the same total plaque burden. And so how you can follow people with coronary calcium and integrate it with your nutrition, with your overall prevention program. And the other thing that's been part of this is doing the CRAFT score. Again, that's essentially the glucose tolerance test instead with insulin, and show how helpful that can be. We just did a 23-year-old, actually the son of one of our patients, who had put on a little weight, and 23, he already has clear, and you would never say he was fat, he has clear insulin resistance, and he already has some beta cell dysfunction at 23. His A1C is 4.6. And so everybody says goodbye and good luck. So picking up those patients and our experience with interpreting the CRAFT test, that's something that everybody can do in their offices. It's a pain in the neck. It's 5 blood sticks. Hopefully soon it'll be a finger stick, but it's not expensive, and it's just been a huge help in our evaluation of patients. And I'll show some of the Dr. Ben cases, and it's cases where small particles alone in some families are the reason for the coronary disease, and they're not from atherogenic lipid profile. They're not from insulin resistance. We have some other sort of genetic cases that are not that unusual. So I'll really review how we approach prevention in individual high-risk patients, and diet and insulin resistance, and as well as exercise, are central, but they mix with a bunch of seeds of genetic factors, and show a bunch of cases of how these all fit together. And so how hopefully everybody can add that, particularly with the diet, as you have, with adding the resistance training and the Dr. Ben approach to your low carb
lifestyle. Yeah, no, I did. It's been an epiphany. It really has. Thank you so much for taking the time to do this. I really look forward to meeting you and listening to your talk in August. And we make sure that we find a way or find some time to put you through a workout with Ben.
Good, Doug. I can't wait to get back to a real meeting.
Yeah, me neither, man. It's like I'm aching.
And to meeting you as well. And I've watched you on tape on the Ben YouTubes for a long time. So you're my guy.
It's funny. There's a lot of people that still don't know that that's me or who I even am. But that's okay. It's all about the demonstration. It's not about me.
You've been listening to an episode of the LowCarbUSA podcast. You can support us on Patreon at patreon.com/LowCarbUSA.